today, and towards the end we'll talk a little bit more about domestic violence in elderly couples. And I apologize, I don't know what y'all are seeing. Are they seeing me and the thing, or just the slides? Okay, I apologize for that. Let's see. Okay. In Texas, and these are 1998 statistics, there are about 1.9 million Texans who are older. And the Adult Protective Services, and you know that that is the organization that is, has the power to investigate problems with the elderly. They had 52,000 plus investigations and 32,000 confirmed cases of what they considered elder abuse. And we'll talk about what elder abuse is as we go along. Also, there were about 8,000 mental health, mental retardation. And I apologize to those on your off-sites. You don't have the handout, but they'll send it to you. So you're in pretty good, I hope that you will get those soon. The vast majority of cases usually involve neglect. You know, when we think about abuse, we think of really horrible things happening to people, and there are horrible things that happen to people, but there are also things like not taking elderly people for their doctor's appointments, getting their medication, giving them adequate food, or just basically letting them live in a way that is not helpful to themselves, so neglect as such. All right, now is this going to just go, I have to do this every time, or just push the, just the other one? Okay. Arrows. Gotcha. All right. All right, this is a breakdown of the investigations and who the perpetrators were. And you'll see from this that the majority of the people that were involved in elder abuse were adult children. I've done some research in the past on adult children and their relationship with their parents when they're caregivers. It's a very stressful relationship. And sometimes things happen all the way from forcing people to eat to, you know, taking their house, their goods, their money, their Social Security, that kind of thing. Of the cases that were investigated, you can see that the majority of them were Anglo, 46.4. And then the Hispanic and African Americans were about even, and then we had a category of others. Okay, this is the number for child, excuse me, I do all sorts of abuse. And this is Adult Protective Services, the number for them, and you will have a handout with that on it too. And of course, elders are a protected group. That's not so if you're under 65 or over 18, you don't fall into that group. So those kind of abuses, we don't have mandatory reporting, but when you get closer to the elderly end or the younger end, then we have mandatory reporting, and we do things more in terms of enforcement of not being abusive to people. So we have actually, I believe in the 70s, the British started talking about nanny bashing, is what they called it, where people were harming elderly people. And that was really the first talk about elder abuse that we have on record. Of course, abuse has gone on in civilization forever. It's not new, but it is something that we have begun to deal with and deal with in different ways. Elder abuse is really defined as omission that leads to harm or that threatens harm to the health and welfare of the older person. And I think that that is important to think about. It's not easy oftentimes when you're dealing with elderly people, and my parents are elderly, and some of yours may be also. And they have a lot of friends who are elderly, and they talk about things that they think adult children should do, like take away driver's license, keep people from driving, or make people eat, or take them out of their houses and put them into more protective environments. And that's very hard to do sometimes. It's hard to tell your parent that even when they're older, what to do. So it's a complex issue and something that we need to be thoughtful about how to move forward. There are a lot of theories about elder abuse, why it happens. Some, and this is what I study, is the long-term effect of violence. If you have violence in your family from a childhood and you see your parents abusing each other, you are abused as a child, you see your environment as being fairly violent, then it seems like it would be logical to think that when you have children, you have a spouse, you have family, that you're going to also be violent. But this is a theory. We don't have a lot of evidence, research evidence, to support a lot of the things that we think about elder abuse or violence in families at all. Another theory that we have is that caregivers, particularly adult children, are under a lot of stress, and this stress leads them to do violent things that they wouldn't ordinarily do. And certainly people have told me that in my research, that they've just gotten so frustrated. Some will say, you know, I'm trying to get the person to take their medication, I'm trying to get them to eat, they won't do it, been criticized for this, and they end up in a struggle trying to force food into the person's mouth. You can see how that might happen to anybody. But I don't want us to say that it's just a normal thing. It's not. We have to think about ways to keep elder abuse from happening. Isolation theory is another one, that people become isolated, and when they're under stress, they're isolated and they can't, they have no resources. One of the things that I found in doing a lot of literature review on this is that the very process of having people come into the house decreases violence. And when I say come into the house, I mean, you know, the garbage collector, the mail person, the meter reader. It doesn't matter who they are, just that there are people that interact, and somehow you break down that isolation. So the number of people that come into the household or have interaction with the elderly people, the less chance you have of abuse. And so there's some sort of protective factor there. Another theory we have is that people are dependent, and dependency has some issues in our society that leads to abuse. And this is a theory that is for child abuse, spouse abuse. The less dependent you are, we theorize, the less likely it is that you're going to be abused. And then we have theories about the abuser. We often look at the abuser as being having psychopathology. They have a mental illness that causes them to be abusive. And in fact, there are some mental illnesses where violence can be a part of it. Paranoid schizophrenia, a small percentage of people will be violent if they're not in control. People with bipolar disorder sometimes can be violent if they're not being treated. But by and large, the rate of, if you look at abusers, mental illness is not prevalent in people who are abusive. My partner, who has worked in the state and federal prisons, he's a psychiatrist, said the first study he did, he looked at all of the prisoners on death row, because he was the medical director for that in Florida, and he assessed them to see if they had psychopathology, if they were mentally ill. And he found out that a very small percentage did have some psychopathology. But the vast majority of people, and these were people who had murdered usually more than once to be on death row, they were normal. And so his conclusion was that murder was normal. Of course, we don't believe that, but that's so what it looked like. So that's really a theory that's very hard to support. And then the theory, again, that an elder person has lost their independence. For every case reported, you have many, many more that are unreported. And this is a slide that shows 70,000 for every about 71,000 that are reported. You have 379,000 that are not reported, and then you have many more instances that are not identified. It's very easy to identify extremely violent, traumatic kinds of injuries. It is much harder to identify people who are being verbally abused or coerced into doing things that they don't want to do. Okay. We have different types of elder abuse. We've had a lot of publicity about elder abuse that goes on in nursing homes and other residential areas for the care of older people, and certainly that is a problem. But much more prevalent is the kind of abuse that goes on within the household, in a person's house. And then even more than that are self-neglect and abuse. So these kind of go starting at the least prevalent to the most prevalent at the bottom. Institutional abuse, we know where those things happen, and usually they hit the press. And in fact, we have people who are specializing in uncovering abuse in, like I said, nursing homes and that kind of place. So that's something that we always need to think about. And there are ways to be suspicious if you're a nursing home supervisor, director, of being suspicious of when a person is being abused. And certainly we need to be very aware of that. It's harder when you get to some of the boarding kinds of homes, when people are more isolated. Again, that isolation theory, the more isolated the person is, the more likely they are to be abused. Okay, you know who those are. The professional staff and paid caregivers fall into this category of perpetrators of institutional abuse. Now, just basic family violence, it's identified as domestic violence. People in family violence use different words, but they're really the same. Domestic sort of implies that there's something, I don't know, domesticated? That just doesn't sound right. So I like to use the term family violence because I think it's more descriptive of actually what we're talking about. And that is the abuse that goes on within a family. Now, there are other kinds of relationships. You know, in Texas we have family law, and that covers people who are married or in a common law situation. It doesn't cover some people that actually may fall into this category of domestic violence, particularly in the elder. You know, a lot of people, as they get older, they make new relationships, and they may or may not marry people. They may have ceremonies but not have a legal marriage, or there may be a group of people that live together. Those people I would include in family violence, but they may not be included in the family code. For instance, when you're talking about intimate partner violence, boyfriends are not included in family law. So you can't get protective orders against them and that kind of thing as a family member. You have to get restraining orders. They're not in that relationship. But a common law husband, somebody that lived in the house for a period of time and was identified as common law, would be covered by family law and the laws that cover abuse. So it's kind of a situation where you have to be careful of what you're doing. But in family violence, we're talking about spouses, siblings, children, friends, intimate people that are maltreating an older person. The types of abuse that we see go all the way, and again, I think if you start at the bottom, you'll see the very most prevalent: financial exploitation, abandonment, neglect, psychological abuse, and then on to sexual and physical abuse. Probably physical and then sexual abuse is probably not as common, although definitely is there. And we have all heard cases and know of cases where this has happened. But it's easy to exploit people. You know, in Texas we're always having warnings about people who are doing house repair, and they take a person's money and they don't do the repairs, or they coerce a elder person out of some money because they've told them, you know, if you give me the money, I'm going to make you some money, that kind of thing. So there's a lot of exploitation. And when we look at other kinds of family violence, spousal kind of family violence, intimate partner violence, this usually isn't covered. It's mainly covered in elder abuse, where you're exploiting taking a person's material wealth. Abandonment, again, we've had instances, and I don't know where y'all work. I wish I had time to find out more about you, because we probably have a lot to share. But you know of cases where elderly people have been taken to the emergency room and left. Sometimes out of frustration. I have heard, actually, I did a series on mental health law, and one of the lawyers stated that she used this tactic to get someone admitted to the hospital when she could not find a physician that would admit a person that she felt needed help, and she herself took this person to the emergency room and abandoned them. It's a way to get treatment. It works, and sometimes you will see that, but there are other ways to abandon people, not giving them food and shelter and that kind of thing. So neglect is very prevalent and very hard to get a grasp on. It is something that there's a fine line between giving someone enough to eat and forcing them to eat. So we want to be careful about that. I think psychological abuse is the fear of any of these other things happening, and oftentimes elderly people will tell me that they're afraid. They don't want elder abuse reported. They don't want adult protective services in because they'll lose their family, and that scares them more than anything else. That fear of abandonment or fear of being punished in some way, fear of having your property taken. Oftentimes you'll hear arguments that family members make about taking somebody to court and get them to get them declared incompetent and then take their goods. And sometimes with, good reasons, seemingly. I have the example in my family of an elder aunt who suffers from depression and has throughout her life, and at times she can get psychotic, and when she becomes psychotic, she gives money to evangelists, a lot of money, more money than she has, and certainly we're all interested in her having enough money to support herself. She's 80 throughout her life, but you cannot, there's no way to force her not to do that. She believes she's doing the right thing, and when she's in this psychotic state, she does things that are not wise. But it becomes very difficult. There's a thin line there between saying, well, this is what she wants to do versus the fact that she is harming herself in the long run. It's very hard to deal with as a family.
If you have someone, say, in a nursing home and their family, who's their responsible party, tells you, don't call me until he dies, I mean, is that considered abuse by the family? Well, they don't want to be notified of anything. They don't want to be bothered by him, so call me when he dies. I mean, is that abuse?
It certainly is. It seems like it is, doesn't it? But I'm not sure. It would really depend on whether or not there were things in place to care for that person. One of the things that I found out, and it was difficult to hear, is that families provide care to elderly people, not always out of love. Obligation is the number one thing that pushes people, and sometimes families will convince themselves that whatever they're doing is enough, and perhaps the person causes a lot of problems in the family. What we've found out through our research is that particularly if the family member was abusive in the past or was an alcoholic in the past, it's very difficult to get a family to want to engage with them and take care of them. So that's a hard question, and I bet there's not an easy answer to it. Because they really are caring for the person by having them in that nursing home, Physical abuse, there are some of the things here listed, and you know of those. Physical restraints at this point is just the hardest thing in the world to justify. It's becoming harder and harder. In psychiatric care, where I am, we don't restrain anybody, and that is really the bottom line. I know it's much more prevalent in the other areas of the hospital, university hospital, where you have people who have medical illness, that kind of thing. But in psychiatric illness, we truly cannot restrain anybody anymore, either through drugs being administered to them without their consent or physical restraint. So we're operating in a different kind of situation, but I understand that it is also getting harder in geriatric settings to use physical restraint. So what does that mean? We have to change a lot of the way we deliver care, and that's what we've tried to do in psychiatric facilities. Okay, you know what physical abuse is. A lot of people don't realize that pushing and shoving are considered abusive with people, but they are. Shaking, we've all heard of shaken baby syndrome. Well, the same thing goes for elderly people. But even when I am doing my research with adult women and ask them about abuse in their lives, oftentimes they will tell me that they're not physically abused, and then when I begin to get more specific, then they will say, well, yes, I've been slapped, and yes, I've been pushed, and yes, I've been shoved or kicked, but I don't consider that being physically abused. The Texas law considers that being physically abused. So, signs and symptoms. Usually, the thing about any of this is if the injury or the situation does not fit with the story, that's when you begin to know that there is a problem. And by that I mean it is very difficult to get a black eye by walking into a door. Sometimes you can see hand marks, fingerprints on people, and you know that they have been grabbed. They may tell you they fell, but the injuries are very specific to body part. So that is, you want to elicit the story, and we'll talk a little bit about that in a minute, and then see if the injury fits with the story. If it doesn't, then that increases our suspicion that there may be abuse. Okay, and these are just some more in terms of, like, you may find excess of medication in their system if you're doing drug screens, or you may find that the caregiver particularly does not want the healthcare provider to be alone with the person. That's always a high suspicion of index, a high index of suspicion, and I'll talk a little bit about how you assess and how you do that in a few minutes. Sexual contact, it is really fairly difficult sometimes to think about sexual abuse, particularly in the frail elderly. But I can tell you that when I was doing rape consulting for Harris County Health Department, a couple of our rape victims were well in their 90s. It's just hard to think about, but it is true. They're vulnerable. They are easy prey sometimes. It's easy to get in to houses, and so you might see that kind of abuse. But sometimes it's a little harder. The person may not be able to tell you. They may not, unless you ask them directly. And I know that it's hard to do, to ask people, is to someone touching you in a way that you're uncomfortable with, or have you been forced to have sexual contact with someone? But when you ask that question, sometimes you're surprised that you get the answer back, yes, I have been. And that goes for men and women. It's not just a woman thing either. So bruises, venereal disease, of course, would give you a high index of suspicion, depending on the circumstance. Bleeding, this kind of thing. Sometimes, just like with children, you may see confusion and fear, and that would make you want to ask a little more questions, and a reluctance to be examined. Also, emotional abuse, again, is harder. Some people don't consider it real abuse. I can tell you from focus groups that I have done with women, when I ask them, what can we do to prevent family violence? How can we protect our young daughters through their lifetimes from abuse? They will say, tell them that verbal abuse is abuse. And if somebody talks ugly to you, it's just going to get worse. And that, I think, is good advice for all of us. So a lot of times, elderly people in particular, and I'll give you an example of one of the women in our focus groups. She was about 65, maybe a couple of years younger. She was in a battered women's shelter, and she was there because her adult son, was abusing her. and she ended up in the shelter because that is a kind of family abuse. She said that her husband always abused her, and he abused her in front of the children, and he left. They split up, and she ended up being dependent, and she lived with her son and his wife. And as she got older, he became first very verbally abusive and then physically abusive. And she ended up in the battered women's shelter. She was distraught. She said that it was hard enough to be abused by her husband for so many years, and to stick by him, but it was even harder when her son began to abuse her. So it's escalating kind of thing. Elderly people, though, can be fearful, and fear of abandonment is a big issue. So if someone tells them all the time, I'm going to put you away, and we hear this, I'm going to put you away, I'm going to take your stuff, put you away, they become very frightened, and that is psychological abuse. Okay. Often you'll see, and I wish I had heard the last speaker on depression, because all of these result in depression. Domestic violence, and oftentimes the first thing we see is a person who's depressed and may have attempted suicide or is in a state of self-neglect, and we find out through time that they have been abused. And I want to tell you that mental health professionals don't always ask this. They treat the depression and they don't get to the underlying cause, so you get them maybe back on track and then put them back in the same situation, and they may become depressed again. So what we're trying to do is get people to screen for abuse no matter what setting that they're in, and I think that that will be more effective in the long run for treating some of the depression, because it may be that if we can stop the abuse, then we may be able to treat the depression better. All sorts of implausible stories. Things are maybe confused. These are signs of psychological abuse. And if you get to know an elder person, and I'm sure that for some of you, you already have known this, if you talk to them, eventually they'll tell you, they're telling me that they're going to have to put me away, and this scares me. It seems to be a pervasive fear in our society. And by the way, I don't always think that putting a person into a protective environment, nursing home or assisted living, is the worst thing in the world. Sometimes it's the very best thing in the world to get them in a place where they can be more stimulated and have more consistent care. Family care is not always the best thing for people, although we tend to think it is. Neglect, I'm going to kind of run through some of this. Mainly in neglect, you're looking at people not living up to their responsibilities. And I'll give you the example of the first woman that I ever really worried about whether I should report. And I spent nights worrying about this woman. I was doing home health nursing. She was in a very affluent part of Houston, and in fact lived in a pool house behind this rather large house, and it was a small pool house. I couldn't get in there at first as a home health nurse because there was this huge dog out there. It was terrifying, and finally I got this little girl that lived there to let me in, and the woman that was living there was a beautiful woman. She was had a master's degree. She had been a librarian in a university, and a lovely, lovely lady. She had terrible osteoporosis and was very crippled with it. Her spine, was collapsing. She had been in the hospital about, I think this was the second or third time, for fecal impaction, and so she had been released. She could just walk a little bit, not very much. She couldn't stand upright, and so she had a wheelchair. She kind of went around in. But she's in this pool house, and it had flooded, and they had pulled the carpet up, and all those carpet tacks. They were just all across the floor in these little wooden strips, the way that carpets are. And so that alarmed me. She also had very, very deformed fingers from arthritis. And the only thing she had to eat was a can of ravioli. And she could not use the can opener. So she hadn't had anything to eat. She was discharged from the hospital the day before, but they had not filled any of her prescriptions and said they didn't know, when they could. when I talked to the daughter, she wasn't sure when she could. She said that mother couldn't come in the house because she had had an accident on one of the carpets, or one of the couches, which didn't make any sense at all to me because she wasn't incontinent or anything. And I wondered if maybe one of those little kids had done it and blamed it on her, I mean, that's possible. But I was so distressed, I felt like she was just not going to be able to stay in there and that she was definitely being neglected. But she begged me, don't tell anybody. And I talked to the physician and he said, don't tell anybody. So you're in a bind. What do you do in a situation like that? Spent a lot of sleepless nights. She was definitely mentally alert, knew what she was saying, and that was a hard case for me. Again, another woman that I did home health with, she had her house had burned and she was living kind of in the garage, and this man lived there. I was not clear what his relationship was, but he sort of took care of her. But she had diabetes, she was blind, she had above-the-knee amputation, and could not draw up her insulin. Filthy situation, just filthy. But again, the physician that I was working with was very reluctant to have any reporting of that. So, all right, we're moving along here. Abandonment, I've already talked about that. Leaving somebody in a public place and just disappearing, that's the most form of it. And financial exploitation, misusing money. We see people taking, Social Security checks or getting permission to cash checks that they shouldn't, or getting access to checks and having them cashed without permission, getting people to sign documents when they can't read them or they're not sure what they're signing, that kind of thing is definitely against the law. Powers of attorney. Self-neglect is a problem. If a person is mentally competent and they understand what they're doing, and again, the two cases that I just told you about, both of those people were mentally competent. There was no question that they were not competent. This leads you to a dilemma, but in fact, it's unclear what we are to do in such a situation if a person is neglecting themselves. Okay, malnutrition. These are things that you may see. Being left unattended. People may become. Okay, we've already talked really about this. 75% of the family members of the victims are the ones who perpetrate elder abuse. It's not something that is often prosecuted. When it is, it's usually an exceptional case that just makes us all cringe, to say the least. But a lot of times the perpetrator may in fact have long-term sort of chaotic relationships with the person that they're caring for. They may be dependent, in fact, on the money that the person that they're caring for has, whether it's their Social Security or whether or not they have more money than that. This is the kind of relationship people get entangled in. They're more likely, the perpetrators are more likely to use substances. Alcohol, of course, is for violent people. Beer is the #1 violent drug in the country. Unfortunately, we consume a lot of beer in Texas. We have a lot of attachment to our beer, but that is usually the substance when we're talking about substance abuse. And they're more likely to have financial problems. They may or may not have a history of violence. You know, the funny thing about family violence is that it's usually contained within the family. People are not just violent. Some people are. They're violent to their coworkers, but you know, that doesn't last long. Usually you get in trouble for that. But people who are violent within their families usually keep it within their families. And sometimes, you know, when it's revealed, we all go, how could that be? You know, we've known this person, we've worked with them, they were a fine, upstanding person, what happened. And that's because we have a social face that we put on, but when we're in our families, we're not always quite so nice. Okay, how do you find out about what's going on? You have to ask the question, and this is a poster, and actually I have a pen, I didn't wear it today, but this is a poster that we have in our emergency room, and we always are asking the question. If we forget, because we have a poster on the wall, then the person that we're talking to may remind us that they're in a violent situation. And we're saying, it's okay to talk to me about family violence, I can listen. So are you being hit, kicked, slapped, or otherwise hurt by your partner? Elder abuse, you can change that word partner to anybody. Your family, your children. Okay. And if you suspect abuse, the main and first thing you have to do is to interview that person by themselves. If they need a translator, you do not use a family member as a translator. You need some other person within your facility that can listen. You want to get them alone if the person that brought them in is very reluctant to have you get them alone. What we always say is we always interview people by themselves first, and then we'll call you in. That's our policy. If it's a policy for everybody, it doesn't bring so much suspicion. But sometimes it's very difficult to get that person alone, and you may in fact have to start off interviewing them, and then I'll show you, if we have a chance, a video where they sort of get the fella out of the room. And it's not always a fellow. Let me tell you that in same-sex relationships, you might see the person that comes in with you, let's say two women, one of them may be the abuser. You also may be in a situation of seeing the younger spouse, woman, being the abuser with the older, more demented elderly man. So don't always think that it's just the, one way or another. It's not. We have to open up our minds. Some of the women that I've interviewed recently about violence have told me of times when they have been violent with their partners. About 95%, and when you're just talking about domestic violence, about 95% of the people abused are women, and about 95% of the abusers are men. But then you have that other 5%. You have 5% of the men who are going to be abused in a relationship. So we need to keep our minds open about that. You want to ask the person if they feel safe at home. This is a big one, and they may tell you about safety issues that are not necessarily what you mean by that, and that's why I don't think you can just ask them that alone, because they may answer questions about, the fire safety, or whether there are rugs on the floors. But and that's important. We want to know that. But then we want to know the next question, which is, has anybody kicked, slapped, hit you in the past year? And then ask them if anyone has forced them into sexual activity, and if anybody is trying to control their money. With the elderly people, that's very important to put in. If you get yes to the answers of any of those, then you need to do a more in-depth assessment. Okay? And the first thing we always want to know, because we value our safety as well as the safety of everyone else, is where's that person who is doing this to you? And if they're in the waiting room, then you need to have a policy in your facility about how you will deal with that. You have to have good support. It's not easy to do work with abused people, because you are hearing things that are terrible, you don't want to hear, and you may take them home. That's sort of vicarious traumatization when we begin to be traumatized by the stories of our patients. But also, in true family violence situations, you can get into a situation where everyone is at risk, and you want that not to happen. So it's better to not escalate that situation. You want to know if they have a weapon. Sometimes they do. We have had instances of weapons being, pulled, and that's sort of scary. Not everybody can afford metal detectors and all those other kind of things, so you want to know. And then if the perpetrator has a history of violence, you want to know about that, okay? If any of those things happen, then you call the police. and get them there while the person's in the room with you, and tell them what's going on. And here in San Antonio, and I'm sure in El Paso, and some of the other places in the South, they will know what to do. That's their job, not ours. If none of those things are true, if the perpetrator's not there and they don't have a weapon and they really haven't had a past history of violence, then the first person to call is Adult Protective Services and get them to do a more in-depth evaluation.
Well, if APS is involved, basically all they're going to do is check out the situation and try to provide some monitoring. I mean, is that not correct?
That is true.
I mean, they're really not able to do much besides that.
They can involve the police, and they have sometimes more authority to do that than just, us sometimes. You need a good working relationship with them, but it is more difficult, I think, with APS than it is with CPS, Child Protective Services. I think that they have a lot of, there's a lot of variation in the kind of response you'll get, put it that way. So if in doubt, I'd call the police first, okay? We have, and I've given you in your handout, and we'll send those out, a safety plan that's specific for older people. And it talks about things that this safety plan that we use for general domestic violence, it doesn't have, like taking medical aids with you and being sure you have your medication and that kind of thing. So that was developed by the Power Group. Lily's part of that, and it works very actively with it. It's a good group, good to think about. Giving advice, and you can give that little brochure to your patients to take home. Although, be careful giving brochures, because even a brochure can cause violence. So we are very careful about what we do. What I would rather do is have them read it, or us read it to them, and then show them where the phone number is. Or give them, some of the physicians that are getting really smart give their cards that have their names on it, and they'll put a list of like the laboratory, and sort of embedded in that is a safety number, so it's the laboratory, the x-ray people, family violence, but it doesn't say that, it says something else, and and you can show them that and say, if you need help, you call this number, or better yet, call 911. And so be careful with what you give people. I just heard a horrendous story, not about giving a safety plan, but about something else that a person gave that ended up in a woman being murdered, which just makes me cringe. So if there's a problem if the person tells you not to do anything, and I've told you about a couple of those. If a person is cognitively okay, I believe that they know their abuser better than I do, and they can predict what they're going to do better than I can. We don't have a whole lot of safety nets. You've said, what is APS going to do? Until we have those, I'm reluctant to force people into situations if they say, don't tell, this will end up in hurting me more. So I have to, but I've got to be really sure that they are cognitively okay before I do that. But I do think power and control issues, we in healthcare have power and control issues. We want people to do what we tell them to do. So we often say, to women, why don't you leave? You need to get out of there, and that may not be helpful advice. They may not be able to do that.
Can you make an anonymous report to APS?
Yes.
Or do you have to give a name?
No, I think you can call them, yes. Now, whether or not they will follow up is a whole nother thing, but
if you think somebody's actually self-neglecting themselves or self-abusing themselves, and even though you know that they're cognitively with it,
you ask them to go make a evaluation. Yeah.
You still would call them and say, whether they ask you not to or anything else. I mean, I would still think that yes.
If you feel like that you need to do that, then I think that that's what you need to do, and you're the best judge of that. I would, in a lot of situations, feel better if they were involved somehow, with them. But again, that's an ethical dilemma. We know what we're supposed to do legally, and we need to do that. Morally, then, you have to make that decision. You really do. Okay. Sometimes the elder may be involved in substance abuse themselves, And that leads to a whole lot of problems of self-neglect, as well as making them more vulnerable to things like falling and hurting themselves. So that is an issue. We often forget to ask people about their substance use. One of the people that's at the School of Nursing has done some research on people giving up their driver's license voluntarily, and as she was doing that, she just asked a question about alcohol and just was astounded. And this was in Nevada, not Texas, but Nevada, because we were wondering whether people would be so honest in Texas about their alcohol use, because these are all people who are over 75. And she said it was like way high, 60–70% that drank, quite a bit before they went to bed. So, okay. And we know about Adult Protective Services. That is our designated agency. But the police, particularly if you're in rural counties, frontier counties, the police are your friend, and that's probably where you ought to go first. So we did, Dr. Joe Thornton and I did a program for Texas Medical Association on abuse, and I was surprised at the number of family practice physicians, and these were mainly from outlying counties, far counties, that did not know that Adult Protective Services existed. So that was sort of really took me back a lot when we talked about it. So I would think that the police are still there. Maybe the presence of Adult Protective Services in more less populated counties is not as it is here. Obviously, that would be true. And then Medicaid fraud is a problem. Medicare fraud is also a problem. This is a Medicaid fraud unit. The Attorney General is very interested to hear about Medicaid fraud, and I just add that for your edification. This is Elder Services, 800 numbered, 800-677-1116. Will locate services in any community in the United States for elder people. And this is good for those of us who have parents in another state, and we're in this state, or relatives, and you want some help. You can get it with this 800 number, even in another state. And of course, in our state, usually the Council on Aging or when it will have information for you. Okay. Let me just tell you a couple of our little cases, and then I'm going to quickly show you just a couple of clips from this video. We thought when we began to audit charts on domestic violence that by the time, because we've heard by the time you get 60 or so, the violence stops or people have split up or whatever. And so we, as we were reviewing charts, one of our first cases was a couple. They both ended up in the emergency room, and the husband ended up being arrested, where he had gotten upset at the breakfast table and took off his shoe. A woman was 85, and he began to beat her on the head and gave her a depressed skull fracture from doing that. And she, I guess, had fought back, and he ended up with some cuts and had to have some stitches. So they both came to the emergency room, and then they arrested him, and he was 90 or something, and you're thinking, whoa, how does that happen? We were all shocked in our, so that tells you that it may not stop with age. You need to think about that. And mainly documentation, I encourage you to write what you see and what people say. It's not important for you to make a decision whether it's the truth or not. It's just important to put down what the person says and whether the injuries are consistent. So if they say, my husband beat me up, and I could give you a really funny example. I've been working with this forensic dentist, and he was called in on a case where this person was drinking, and they thought they had been sexually assaulted and that they had been bitten. And so he was looking at the bite, and he said it was not a bite. He couldn't tell what it was. Well, anyway, as the story unfolded, the person was drinking, and they were climbing across a picket fence and sat on the picket fence, and it sort of looked like a might have been a bite, and the people investigating were concerned that they had been bitten, but in fact it was a picket fence stuck in their leg as they were climbing over the fence. So it's not always what it is. So you listen to the story and document what you see, and get, we take pictures and keep those but you can, if you've got a frank case, you call the police. They'll come and take your pictures. You don't have to worry about that, okay? Can we just show a little bit of that clip? I've got some websites on your handout for help. And yes. And then I know I started a little bit late, so you tell me, Lily, when I need to stop.
Sophisticated, beautiful women are being battered every day, and people need to know this.
I was walking home from church. We don't live far. And my husband pulled up in the car. He offered me a ride home. When I got in, he pulled out a knife and put it to my throat.
If he couldn't degrade me at home, then he'd give me a noticeable bruise, which I'd then have to explain to my sister, friends, neighbors, whoever.
He slapped me repeatedly on our honeymoon. I couldn't believe it. I couldn't admit to myself that I was one of those abused women. I didn't fit the stereotype.
Healthcare settings are a safe, comfortable, and appropriate place to discuss issues of domestic violence. Screening should be part of the routine.
Morning. Hey, Joan. My name is Mary Elizabeth. Nice to meet you. You're here for your preventative check?
Yeah.
Okay. And it's been, let's see, 4 years.
I guess so.
Okay. We really would like to see you a little bit more often, maybe every 2 or 3 years. Do you smoke?
No, I quit.
Good for you. How long ago?
Oh, it's been a while, 10, 12 years.
Great. Any allergies?
No.
And alcohol consumption, once every day, week, year?
Hardly at all, once a month.
Okay, let's get your blood pressure. Ooh, that's quite a bruise you've got.
Yeah,
there.
it's from a leash. I took our dog for a long walk, and he's a strong dog, and I bruise easily.
Yes, I see. Is it tender at all?
No, no, it's fine.
Okay.
Domestic violence will affect nearly 1/4 of U.S. women during their lifetime. Statistics show that women leave their abusers 6 to 8 times before leaving for good. The violence cuts across ethnic, gender, age, and socioeconomic lines. It's present within both heterosexual and same-sex relationships. It's a complex, massive problem.
Blood pressure is 104/80. It's good.
Because of the hidden nature of abuse, the victim should be provided with validation, support, and information which will assist her as she finds her own solution to the problem. Healthcare professionals cannot cure the problem, but they can be part of the solution by becoming comfortable with routine screening for domestic violence.
Okay, Joan, as part of the visit for all of our female patients, we're asking a few routine, confidential questions about safety issues, and that's because your personal safety, how you get along at home, at work, it all affects your health. So, how is everything at home, at work?
Oops, okay, it's fine. What do you mean by safe?
Well, safe as it relates to relationships mainly. Do you feel supported, respected, trusted at home? Is your partner ever physically or emotionally hurtful to you?
No, of course not.
Oh, good, because, you know, that just isn't the case for a lot of women. We want women to feel that the clinic is a safe place for them, that we're a resource. We also have these pamphlets. There's one on domestic abuse, and we've got the power wheel here on relationships. So feel free to take one if you'd like, if you have a friend that may need one, or maybe it's just enough to know that they're here. Okay, well, here's your gown. It opens up in the back. Why don't you go ahead and get undressed, and the doctor will be in just a minute.
Even if your routine domestic violence screening leads you to suspect that abuse has taken place, as a healthcare provider, you must remain respectful of the patient's response. If a patient is in a healthy relationship, then the screening may be seen as a simple extension of overall health maintenance.
Trust and support, shared responsibility, negotiation, and fairness.
If a person is experiencing abuse, the simple act of screening for domestic violence can begin to break the isolation.
Using coercion and threats, intimidation, isolation, using children.
The patient will use her own timetable to decide when to seek a solution.
I'd been given a pamphlet that had a 24-hour phone number on it, but it was too dangerous to let him see. So I taped it to the back of my refrigerator for 9 months. Until one day, I was ready to call. For me, I decided when he pulled out that knife that the next time he might use it. That's when I left.
I always thought that it only affected me, that it was only my pain, but then he told my 3-year-old daughter, he said, go over there and tell your mother that she's stupid. I was nursing the baby, and he said that. And, you know, he was the papa, so she told me I was stupid. And I thought to myself, if I stay here, he's going to convince my daughter that I'm crazy or something.
You have to understand how I was raised. Women my age were taught to be submissive, passive. You support your husband, you stay with him no matter what. Oh, I had no job skills, no way to support myself, so I felt trapped, absolutely alone.
Isolation is a common tactic and also a result as the abuser seeks to dominate and control the life of his partner.
So comfortable. And Mike, you can sit over there if you'd like.
No, that's fine, thanks.
It's good to see you again. You look wonderful.
Thanks.
Last time you were experiencing some nausea in the morning. Do you still have that?
Apparently not. She eats like there's no tomorrow. How fat is my wife going to get anyway?
Well, that depends upon the woman. But the average weight gain is between 25 and 35 pounds. And Becca, you're right in that range. How are you feeling now that the nausea's gone away?
Good. I feel good.
Then why don't we get you to hop up on the table, and we'll see how the baby's doing. Mike, this is a routine part of the exam that's private for the patient, so I'm going to ask you to step out into the waiting area until I call for you.
Hey, I'd like to know how the baby's doing too.
Oh, don't worry, I'll let you know everything about the baby. Now go ahead, step out, and the nurse will show you to the waiting area. I need to collect a urine specimen, and then Becca and I are going to discuss some female things.
Never screen for domestic violence when the partner is present. One option is for the provider to escort the partner out of the room while the nurse screens the patient. Pregnancy can actually be a trigger for abuse to begin or to increase in severity. Be alert to physical, behavioral, or psychosocial problems which may be caused by domestic violence.
That's quite a bruise you have on your abdomen. How did that happen?
Oh, I wasn't paying attention and I ran into the door. Mike says I'm clumsy.
Oh, gee, it looks like it hurt an awful lot. But I'm a bit puzzled, Becca, because of the shape of the bruise. Rounded like that? Doesn't look like it happened from a door. It's more consistent with the shape of a fist, as though someone might have hit you. How are things at home? You know, you and I haven't been alone since our initial visit, and you said things were fine then. Is that still true?
I really can't say anything.
Becca, anything you say to me is confidential. Your medical record, that's also confidential.
If abuse is suspected, remain non-judgmental. Don't push the patient or tell them what they should do. They need to feel safe.
how people get.
We're going to stop it right there. I know that this is not specific to older people. One of the scenarios as it goes along is more an older woman, but the concepts are the same, to get the person that you suspect out of the room and ask the questions and question the things that don't make sense in the story, that kind of thing. So I encourage you to look at your resources in the community, see what you have and where you can refer people. Do that first. Make your community resources available to you and your referral sources, and then start asking the question. Okay?
What goes up must come down.